This is the Derm on RheumNow podcast. Hi, I'm Dr. Jack Cush, editor of RheumNow.com, and this is the August 2025 edition. Derm on RheumNow is content curated for dermatologists and you skin-deep healthcare providers who are interested in all things derm. We cover a lot of rheumatology on RheumNow.com, but we also cover lupus, vasculitis, psoriasis, hidradenitis, and derm drugs, their use, efficacy, safety, a lot that is of interest to dermatology. So we're going to cover items that I put out there on social media and post up on our website, RheumNow.com. This includes feature articles and tweets. So let's get to it. Our first is a report on the cardiovascular risk associated with CLE, chronic cutaneous lupus erythematosus. This is a retrospective claims data analysis of a large number of patients. Specifically, they're comparing patients with CLE, over 8,000, with 24,000 systemic lupus patients, 192,000 psoriasis patients, and 81,000 controls. After a lot of adjustments and multivariate analysis, when you look at the outcomes as far as atherosclerotic cardiovascular events over a 3-year period, the rate was lowest in controls at 10 events per 1,000 patient years. That's 1,000 patients followed 1 year, 10 events, etc. In psoriasis, it's up. It's 40% higher at 14 per 1,000. CLE is like psoriasis. It's at 15 per 1,000 person years. And lupus is the highest at 25,000 per 1,000 patient years. So 1,000 patient years, convert that to 100 patient years, it goes from 25 down to 2.5 per 100 patient years. That gives you a relative risk as you might consider that for your patients with chronic lupus. So we're worried about comorbidity and cardiovascular comorbidities in chronic psoriasis patients. We should also be worried about it in other forms of chronic cutaneous inflammation, including lupus and CLE. Another interesting claims data study was published this past month coming from Joe Marola and colleagues at UT Southwestern. This was looking at the safety of using what he called combination targeted therapies. So while one of the big things going on in psoriasis right now is that there are these combination biologic studies that are in play. The early story is that they look to be safe, but we're going to see what they do. We need the results. So Marola and colleagues actually looked at a large number of PSA patients, 82,000, and found that about 1%, or specifically 542, were on these CTTs, combination targeted therapies. But it's not what you think. It's really apremilast plus an IL-17 inhibitor, or apremilast plus a TNF inhibitor is the two biggest groups here, but other combos are also in play. And the question is, when you were taking 2 of these drugs, were you at higher risk than if you were taking just 1 of these drugs? And it turns out when it comes to serious infection, you're at no higher risk. The rate ratio is below 1, it's 0.53, so it's actually 47% lower, but it crosses over 1, so it's non-inferior to taking 1 drug, or not any more serious than taking 1 drug. Opportunistic was exactly 1, again, crossing over 1. So it turns out, again, this report, since this claims data, can't look at efficacy, but they are looking at safety, and that is one of the main concerns, is it not? We need more data on combination therapy in patients with difficult psoriatic disease. You need it in dermatology, I need it in rheumatology. One thing that we rheumatologists have learned from the dermatologists is this term, JAKne. What? That's right, acne occurring with JAK inhibitors. And I've reported a lot on it in the last 2 years, 3 years, and my rheumatology colleagues say, I never see it. And I had to admit that most of the reports were coming from the dermatology literature. But here I found a report that comes from patients with IBD. So this is almost 2,200 IBD patients who are taking JAK inhibitors, and more than 10%, 272, develop acne. So that would be called JAKne, would it not? Again, the actual drugs that were implicated here, it happened in 16% on upadacitinib, 4% on tofacitinib, 2% on filgotinib, and for UPA and TOFA, it was dose dependent. The more higher dose you use, the more the risk. Again, I don't know what this means, and maybe you do, being in the field, but patients who had a prior history of acne vulgaris had a 5-fold increased risk of getting JAKne if they went on a JAK. Now, is that recurrence of their acne, and it's being attributed to the JAK? Is that the JAK flaring the acne? Does it even matter? What you'd have to know is what happens if you stop the JAK. Does the acne flare go away? Anyway, the patients who were more likely to get this were between the ages of 30 and 50, had mild to moderate severity, and then they tended to get it in the first 3 months. Watch for the JAKne. It's coming to a clinic near you. Nail fold capillaroscopy, we do it in rheumatology. I assume sometimes you do it too. A review of its use in 258 patients with systemic sclerosis and controls found that the most specific finding on nail fold video capillaroscopy was giant capillaries, these big dilated tortuous vessels that had a specificity of 98%, and then capillary density, aka dropout, that was best at defining a scleroderma pattern on nail fold testing. So dropout was defined as a density of 8 or fewer capillaries per millimeter. That had an AUC of 91%. Again, having both these things, while found in 39% of patients who had scleroderma, ultimately, it had a 91% accuracy when it was found. Interesting to note. Another thing of concern to both rheumatology, dermatology is whether psoriasis patients are at a risk for developing psoriatic arthritis. A lot written about this, as you know. This is sort of a problematic area. And 3% of the population has psoriasis. Up to 30% of psoriasis patients will get psoriatic arthritis or develop it. It tends to be more likely in patients who have more severe skin disease. And there's a number of tools that have been developed that you could use, and these are survey tools that you can use in your clinic to know who to refer and whatnot. And that includes the PEST and the PASE and EARD and TOPAS surveys. I'm going to tell you, based on this report, just order an MRI and an ultrasound to figure out who you need to refer. So this was a meta-analysis of 12 studies. Included 1,600 psoriasis patients, 327 PSA patients, and 686 controls. It turns out, amongst all these people, that if subclinical synovitis was found, meaning these patients didn't have swollen joints or complain of swollen joints, but was found on either MRI or ultrasound, that was 2.5-fold more likely to be found amongst people with psoriasis. So your patients with psoriasis are at risk. Detection was higher than with ultrasound. So ultrasound gave a relative risk of 6.4. MRI, a relative risk of 6.4, ultrasound 2.5. So again, something to consider as a screening tool. I think that this is valuable, and you could be done in lieu of or as a first step before you refer to rheumatology. Think about it. 2 more reports. One about the efficiency of ANA testing, something you deal with. Everyone in medicine deals with this. This is a large cohort study from a federal hospital system where they did chart reviews when ANAs were ordered. It's on 2,500 individuals. Turns out that 97% of the ANAs that were ordered did not lead to a rheumatic or autoimmune diagnosis. Again, a lot of these were being done for a lot of reasons. Most of them were being done in primary care. Of those that were ANA positive, 13% were diagnosed with a new autoimmune rheumatic disease, most often Sjogren's, lupus, and undifferentiated connective tissue disease. In the ANA negative group, only 1%, 1.6%, were diagnosed with a new autoimmune or rheumatic condition, and that was most frequently RA or spondyloarthritis. So the point is, and one of my teaching is, don't order an ANA for one reason. You need like 3 or 4 reasons. You need 3 or 4 good criteria or symptoms of lupus to make ordering the ANA have clinical utility. If you're ordering an ANA with someone with arthralgia, it has almost no predictive value. If you order an ANA in someone who's got arthralgia, Raynaud's, a malar rash, and a family history, well, now it probably does mean more. So again, you're ratcheting closer and closer to the diagnosis once you find that positive result. The last report is about a TYK2 inhibitor. You have deucravacitinib currently approved for use in psoriasis. We don't have it approved for psoriatic arthritis, although that may happen later this year. Another TYK2 inhibitor in development is called zasocitinib, TAC-279, made by Takeda, and they reported their phase 2 clinical trial results on almost 3,000 psoriatic arthritis patients who were randomized to receive either placebo, 30 milligrams, 15 milligrams, or 5 milligrams once a day. The primary endpoint was 12 weeks. It was a 1-year study. The 12-week outcome, and this was an arthritis outcome, was obviously showed efficacy for the 30 milligram and 15 milligram dose, both having more than 53% ACR20 responses. That's a ACR20 is a composite arthritis response of 7 variables, where you have to improve in each variable by more than 20%, at least 5 out of 7 times. It's actually hard to achieve. It's not 20% improvement. It's actually much more than that. The placebo response was 29%. So the delta over placebo, the treatment effect is 20%, and that's pretty good. That's enough to get you into a new large phase 3 trial. So that's encouraging. There might be more than one TYK inhibitor out there in the market, and the question is, how will you use it? And you'll probably teach us in rheumatology how to best use a TYK2, because we're certainly going to need that advice coming up later in 2025. There were no new safety signals in the study indicating, again, its safety going forward. So that's it for the first episode of Derm on RheumNow. Tell your friends. We'll do this once a month. Look for us in September.